Good morning, good afternoon, or good evening to everybody, depending on where you are in the world. All right, so the topic today is cataract surgery in eyes with glaucoma. My name is Malik Kahook. I am professor of ophthalmology at the University of Colorado, and really happy to be on this conference today. Throughout this discussion, if you can write down some of your questions that might come up, you have the ability to share those questions. And we'll get to them towards the end of the discussion here. I think it's going to be around 35 to 45 minutes or so. And then we'll have some questions interspersed within the slides here, so we can get some participation that will hopefully allow us to share a little bit more when it comes to what type of questions you might have. These are my financial disclosures. I work with several companies in ophthalmology. There's really no direct relationship to many of the products that I'll be discussing. One from New World Medical is one that I work with closely, and I think that'll be obvious when we get to it. The objectives today, we'll be talking about MIGS, micro-invasive glaucoma surgery. We'll do an introduction to begin with before we get into cataract surgery for IOP lowering. I'll talk a little bit about goniosynechialysis because I think it's an important skill for any patient who has glaucoma and cataract. Many of these patients can benefit from that procedure. And then at the end, we'll talk about some pearls for practice when we're combining glaucoma surgery with cataract surgery. I'm going to start off with a case here. This is a 62-year-old male that I treat, has a 12-year history of primary open-angle glaucoma on latanoprost and dorzolamide. Pressure is 18 in the right eye, 16 in the left eye, and the goal pressure is 16 in both eyes, so not that far away from goal on the right eye. Visual field deficit is stable over the last 3 to 4 years. Patient has a visually significant cataract in both eyes, and the angles are open to the posterior trabecular meshwork. He admits that he forgets to use dorzolamide a few times per week, which probably means he's not using his dorzolamide or his latanoprost at all. And the question is, what is the next step? This is something we're hearing a lot about in ophthalmology, MIGS procedures. The definition is any surgical manipulation or device implantation, typically combined with cataract extraction through a self-sealing incision with minimal trauma to surrounding tissues, and it results in measurable sustained decrease in intraocular pressure. If I had a MIGS wish list, it would look very much like this. And as you can see, there's a leaking bleb with fluorescein on the right-hand side. I'd like to avoid a bleb at all costs. I'd like something that's as effective as a trabeculectomy, but much safer, something that's reproducible and predictable, something that's easy to perform with less post-operative effort, and of course, anything that could be cost-effective for global care of glaucoma would be beneficial to all of us. So in my opinion, when you look at that wish list, cataract surgery is actually the best MIGS procedure that we have. We use a small cornea-based incision, excellent safety, proven sustained IOP lowering, and all options remain for future interventions. We don't really take anything off the table, whether it's a traditional MIGS procedure or more invasive surgeries like trabeculectomy or glaucoma drainage device. And I think part of the issue here is we're seeing a paradigm shift in the way we think about treating glaucoma. Typically, as glaucoma surgeons, we swing for the fences. We try and actually get the best possible IOP lowering. Unfortunately, that's usually coupled with an increase in risk. So a trab and a glaucoma drainage device, these have been the traditional methods, but sometimes a lower risk procedure with maybe a little bit less IOP lowering is appropriate, similar to the MIGS or cataract extraction in the bottom left-hand corner that you see here. One of the reasons that I think we're looking at this more and more as far as MIGS or cataract surgery being an effective treatment is the fact that a lot of the trials looking at the MIGS devices reveal that cataract surgery alone has a tremendous amount of IOP lowering. So you see the bar graph on the right-hand side. In the middle there, that's the effect from cataract surgery alone. And then the coupled effect from a typical MIGS implant is really a small fraction of that. So you get a lot of IOP lowering just from the cataract surgery alone. Now, the science of IOP lowering when it comes to cataract surgery is something that is evolving. We know that the level of IOP lowering after cataract surgery is probably due in some part to a remodeling of the trabecular meshwork, probably linked to something called E-selectin or IL-1. This is similar to the changes that you might see post-trabeculoplasty, whether it's argon laser trabeculoplasty or SLT, selective laser trabeculoplasty. There is a remodeling that happens with the effort of doing cataract surgery and the flow of fluid around the eye. we routinely see significant and persistent IOP lowering, even when the preoperative angles are wide open. And this is a really important distinction. You don't have to have narrow angles with the deepening of the chamber after cataract surgery in order to get that IOP lowering. Now, having said that, a lot of people have spent a great deal of effort in trying to elucidate the reasons for IOP lowering. This is one of the seminal studies looking at E-selectin, or change in the cytokine levels within the anterior chamber and what might happen to the trabecular meshwork. It's a little bit of a busy slide, but basically what you see here is that after introduction of ultrasound into a medium of healthy trabecular meshwork or glaucomatous trabecular meshwork, you see a change in the cytokine level within the fluid that could also lead to a remodeling of the extracellular matrix, which then enhances the outflow of fluid from the eye and decreases intraocular pressure. There have been a great deal of studies also looking at the angle anatomy, and we do know that the level of IOP lowering after cataract surgery is proportional to the resultant widening of the angle. And that might seem to differ with what I just said about wide open angles having a decrease in intraocular pressure, and that I think reveals what work we have left. We need to tease out the differences between narrow angles decreasing in pressure after cataract surgery versus wide open angles that also decrease in pressure. It's probably a factor on both sides, that it's multifactorial, and we're just trying to tease out the differences. We do know that lens vault may be predictive of IOP lowering, and there are things that are being studied right now through gonioscopy and anterior segment OCT, like angle morphology, characteristics of the iris, how thick the iris might be in the periphery versus centrally, and the lens vault. There are a lot more studies that are ongoing to tease out the exact differences in lens vault in patients who might decrease IOP versus those who don't. We know that doing cataract surgery alone in patients with chronic angle closure who have significant anterior synechia is not as effective, and that's also something that we'll talk about a little bit later in this session. One pearl, just because we're talking about cataract surgery and glaucoma, if you do have a patient who requires an LPI, and you know that this patient will be going for cataract surgery, which is the overwhelming majority of these patients, try and put the hole in the iris right beneath where you plan putting your incision for cataract surgery. And the reason for that is you'll have less likelihood of the iris coming into the wound at the time of cataract surgery if there's an LPI right beneath that cataract incision. So the science of IOP lowering, you can tell, is pretty complex and still being studied. ECM remodeling and change in angle configuration are both relevant to the mechanism of IOP lowering, and studies are underway with advanced imaging as well as protein sampling of the fluid to better understand the process. What about acute angle closure? This is also a topic that we're hearing a lot about in the glaucoma circles, and it also has a similar conclusion that Phaco is a great option. Dr. Lamb studied this in 31 eyes with acute angle closure and cataract surgery and found that Phaco had lower IOP, less medication, and better visual acuity compared to the standard of doing a laser peripheral iridotomy. And you can see here from the table the comparison of the present study. This is the Lamb study with 31 eyes, showing that the prevalence of IOP rise at different follow-up time points is very favorable for the cataract surgery versus medications and LPI. This was further examined in the EAGLE trial, and we're just now starting to understand some of the results from the EAGLE trial. And in full disclosure, this is something that I'm still digging into, trying to figure out a little bit more about the nuances of the study. The study itself looked at the best approach to treating primary angle closure glaucoma with either standard of care, which is medication and LPI, versus lens extraction. Age of the patient was 50 or over, pressure 30 or higher. 419 patients, so this was a robust study. 208 assigned to clear lens extraction or lens extraction, and 211 to standard of care. Pressure was 1.18 millimeters lower in the lens extraction versus the standard of care. The conclusion here is that lens extraction showed greater efficacy, marginal if you look at the exact number, but was more cost effective than doing standard of care and should be considered as first-line therapy. This is something, again, that we're still trying to tease out the details, but it's very encouraging to see that cataract surgery alone could be quite effective and also cost effective. Chronic angle closure, a little bit of a different story here when it comes to chronic angle closure. A study in 2008 looked at medically controlled chronic angle closure glaucoma and found no difference in IOP after 3 months when you're comparing Phaco to Phaco trabeculectomy. Phaco trab was on less medications but had more complications, as you might imagine. In 2009, the same group looked at medically uncontrolled chronic angle closure glaucoma. Phaco alone lowered IOP by 8 millimeters of mercury. Now, on the other hand here, Phaco Trab lowered pressure 13.6 versus 15.9 when you combined with Trab. Mean of 1.25 less drops, but it had more complications and more progression of the optic neuropathy. So there are a lot of inconsistencies here in the study, and we're still trying to figure out the best way to treat chronic angle closure. And I'll talk about that a little bit more when I talk about goniosynechialysis. This is a study done by Dr. Mansberger out of Portland, looking at the intraocular pressure effects of cataract surgery in patients in the OATS trial. 42 participants, 63 eyes, versus a control group of 743 eyes that did not undergo cataract extraction. Looking at the preoperative IOP, which is defined as the IOP of up to 3 visits prior to the split date, and then what happened to the IOP after the split date. If you're not familiar with the split date, it essentially looks like this, where you have the intraocular pressures to the left-hand side of the 0, showing what the preoperative pressures were before cataract surgery. And then after, to the right-hand side of the 0, you see the cataract surgery. There's a big dip in intraocular pressure versus the control, which remained fairly steady. And the conclusions here is that the estimated mean decrease in IOP post-operatively in the cataract surgery group was 4 millimeters of mercury, quite significant in this group. And the control group had almost no decrease in pressure, 0.3 during that follow-up. Just to dig into the numbers a little bit more, this is one fact that struck me and has influenced my care of these patients. A significant number of these patients, so about 40% of these patients, had a decrease in intraocular pressure of greater than 20%, if you look at the first 2 lines here. So that is a significant number that I think can help patients, and I typically put this as part of my surgical care of patients who come in with ocular hypertension who are high risk for advancing to glaucoma. On the other hand, I do want to highlight this last line, that there was an 11% increase in intraocular pressure. So just seven eyes in this case, but it's something that you have to keep your eyes on, that not every patient has a decrease in pressure. And in fact, some patients might have a slight increase in pressure that could be significant for that particular patient and requires follow-up. When I first started thinking about cataract surgery for IOP lowering, these papers were starting to come out from Poli and colleagues, along with Dr. Lindstrom and Samuelson out of Minnesota. And you can see here in eyes with high pressure ocular hypertensives or normotensive patients, there was a significant decrease in pressure that correlated with the starting pressure. So if you had a pressure around 31, there was a high likelihood that you would decrease your pressure by about 27%. And the effect decreased as your pressure decreased from the preoperative levels that you see on the left-hand side. This was not earth-shattering because we did know that there was a decrease in pressure that correlated with the starting pressure. However, this was one of the first studies to look in large numbers at the decrease in intraocular pressure after cataract surgery alone. They took this a step further, just looking at glaucomatous eyes with this table here, and you see that there's a similar effect. The glaucomatous eyes had a significant decrease in intraocular pressure that correlated with the preoperative pressure, and in this case, up to a 34% decrease in preoperative pressure compared to the preoperative pressure in patients who had a pressure between 23 and 29. In addition to that, the mean number of glaucoma drops was 1.3 before surgery and 1.0 at the final measurement. So there was, if anything, a slight decrease in the use of medications along with this robust IOP lowering. And I think that also pushes me more towards doing cataract surgery earlier in my patients who have glaucoma, particularly those who are having a pressure check where you're getting above the 22 millimeters of mercury level. So we're going to go to the first question, and Lawrence is going to take over here while I read this question. Which mechanism has been linked with IOP lowering in glaucoma eyes post-cataract extraction? Trabecular meshwork with ECM changes related to ultrasound? Degree of lens vault preoperatively, both A and B, or none of the above? So we have 58% saying both A and B, and that is the right answer. So I'm going to advance the slides here and just highlight that. Now, we covered in the first few slides that there are 2 mechanisms that are being studied extensively. One is the change in the extracellular matrix induced by cytokines after ultrasound, and also the degree of lens vault preoperatively and how that might correlate with pressure reduction after surgery. So stay tuned. We're going to see a lot more science about this as time goes by. So it seems that cataract surgery would be an awful control group if you're studying the effects of a glaucoma procedure at the same time as cataract surgery. And what I mean by that is if you're looking at an angle procedure like a MIGS device, and your surgery is cataract plus MIGS device, and your control group is cataract surgery alone, Well, we've seen that cataract surgery alone has a robust IOP lowering effect. So that might cloud how we envision the use of a glaucoma device along with cataract surgery. And we're starting to learn a lot from the various MIGS trials that have come out. And one of the first studies that was pretty robust was by Glaukos, looking at the iStent device. Glaukos is definitely the innovator when it comes to MIGS implants, and these studies have been analyzed from left to right and all the way around. What we see here, simply put, is that the primary outcome of pressure under 21 millimeters of mercury without medications was robust in the iStent group. But if you look at the Phaco alone group, so this is the third column on the first table, you can see that there's still a robust effect from Phaco alone. And the question here is, when do you have to combine the MIGS device with Phaco if Phaco alone is quite robust? And you see exactly the same thing with medication reduction. So IOP reduction greater than 20% without medication, still very robust with both Phaco and Phaco Plus. Follow-up studies to this with other devices, in this case a suprachoroidal device with the CyPass that is now being marketed by Alcon. Before Alcon took over, there were a few studies that were done for FDA approval, and this was the major one, the COMPASS trial, which showed very similar to the iStent that the control group, in this case the control was Phaco alone, was quite robust in IOP lowering both at 12 months and 24 months. You see here at 24 months, 60% versus 77%, looking at the metric of IOP lowering greater than 20% versus baseline. Very robust study looking at a tremendous amount of patients, 131 in the control, 374 in the Phaco plus CyPass. And it shows, I think, quite definitively that Phaco alone does a very good job, and you do get extra effect with CyPass just like you did with the iStent. A third device in this category is the Hydrus device. This is a device that fits into Schlemm's canal. It's 8 millimeters long versus the 1 millimeter long iStent. So we're getting into a place where you're targeting a few more collector channels with one treatment. And you see here that the robust number of patients that were treated showed a very similar effect to the other two studies as far as the cataract surgery patients showing a robust IOP lowering both at 12 months and at 24 months, although you see the trend starting to wane a little bit at 24 months, this is still statistically significant and quite robust from the baseline of around 26 or so, going down to around 19. This makes me feel very good about offering cataract surgery as a standalone procedure for many of my glaucoma patients. Although I do keep in mind that the device implantations here that you're seeing do give me a little bit more of IOP lowering. So a note of caution, we're talking a lot about the positives here with IOP lowering and cataract surgery alone, but the Poli and colleagues' papers helped us understand another aspect to this. 55% of the patients had lower IOP, 30% had higher IOP, and 15% had no change. So in patients who had a pressure less than 55 millimeters of mercury, there was a 55% of patients had a higher IOP in these cases. In essence, what we're saying here is that while you do get robust IOP lowering in many of the patients, in some circumstances, you might get an elevation in pressure. In most cases, not very significant, but you should pay attention to it. And in some cases, the elevation in intraocular pressure in glaucoma patients after standalone cataract surgery can be significant, especially in these post-trab patients where the IOP may increase by around 2 millimeters of mercury on average. That might be enough where you have to increase medications or do something else to decrease the pressure after cataract surgery alone. Keep this in mind when you're treating patients. So back to that case report that we started out with, what is your next step? I don't think it'll come as any surprise to see that the thing that we did in this case was cataract surgery alone. The pressure decreased to 14 millimeters of mercury in both eyes, and the patient was off of all medications, which he probably wasn't taking to begin with. So what we see here in this case is that we were able to achieve our goal pressure and get the patient off of medications that he probably wasn't adhering to anyway. So what is my practice pattern? In glaucoma suspects and ocular hypertensives, I choose to do Phaco alone when they have a visually significant cataract. In glaucoma with controlled IOP and 1 to 3 medications, I typically do a Phaco plus with the main goal of getting the patient off of 1 or more of their medications. Glaucoma with uncontrolled IOP on 1 to 3 meds, I still go for Phaco plus. I try and do a minimally invasive procedure combined with Phaco in order to try and avoid the trabs and tubes that have a higher rate of complications. In most cases, trabs and tubes are reserved for pseudophakics who failed the above. I also try not to combine cataract surgery with trabs or with tubes because I think those patients tend to do a little bit worse with an elevation in their intraocular pressure due to the inflammation that happens with combined surgery. That's my basic practice pattern that I live by. What does evidence-based medicine teach us? Just looking at the science that has been published, I think we can say that Phaco alone is a viable first-line surgical option for narrow-angle glaucoma. Phaco alone is also a viable option for controlled glaucoma on 1 to 2 medications. It can improve vision and a good chance of getting off of 1 drop. In setting of uncontrolled glaucoma with open angles, cataract alone, I think we can say that the evidence-based medicine is still evolving. The patient and the surgeon should discuss this, discuss what's possible, and then consider Phaco plus or sequential surgery. Is it possible to do a Phaco plus a minimally invasive device? Or can we do Phaco first, followed by trab and tube later on, or trab and tube followed by cataract later on? And that's a discussion that should happen between the physician and the patient. In many cases, the art of medicine matters just as much as the science, and that's something that I think we all recognize, that the more we practice, the more we understand that there's a lot of art to what we do. I briefly want to touch on goniosynechialysis and microinvasive glaucoma surgery with specific mention of devices and technique. Who is a candidate for goniosynechialysis? Phakic patients with primary angle closure glaucoma, combined cataract surgery plus GSL. That's an easy decision. Chronic angle closure glaucoma with elevated IOP and at least 50% of the angle sealed with peripheral anterior synechia is a good candidate for combining cataract surgery with GSL. Many have advocated for fresh treatment. So this is a patient who might have PAS that's 6 to 12 months old and not much longer than that. And I think that's controversial. I have treated patients in my experience with PAS that has been longstanding and still see an effect from that. Standalone GSL may have IOP benefits in chronic angle closure glaucoma, but this is controversial and likely dependent on timing. So this is something that's evolving, and it depends on which paper you read or what your particular experience might be. Who is not a candidate for GSL? Eyes with very advanced cupping and central visual field defects. You might want to go to a more definitive procedure. Caution in patients on anticoagulants and antiplatelet therapy. There might be more of a tendency to have a reflux of heme during the surgery with retained heme during the follow-up. Active uveitis or chronic recurrent uveitis, they might have a tendency to be inflamed much longer than just standard cataract surgery alone. So just exercise caution in those cases. This is what the procedure looks like. And one thing I'd like to emphasize here when it comes to GSL, if you don't remember anything else from the technique standpoint, remember that you should pull down and not centrally. So you're basically teasing off the iris from the trabecular meshwork, and you're pulling down in order to do that. If you pull centrally, you might run into problems with a tear in the iris root. And so pulling down is a little bit more gentle and also achieves the end result of teasing off the trabecular meshwork better. Potential complications, as I mentioned before, hyphema, especially patients who might be on blood thinners, chronic inflammation, minimize tugging on the iris, make sure that you're pulling down gently and not centrally. And then you could get iridodialysis or psychodialysis when you're first starting out, which could lead to hypotony. It's rare, and proper technique will help you avoid that. So here's the second question. Who is a candidate for GSL? Only pseudophakic patients? Only phakic patients? Chronic angle closure glaucoma with over 50% PAS, or none of the above? All right, 86% chose the right answer. In this case, chronic angle closure glaucoma with over 50% PAS is the right way to go. Now, only pseudophakic or only phakic, of course, we know that we could treat both. It's not really relegated to one or the other, and that's why the proper choice is C. Now, there are a lot of MIGS devices and ab interno glaucoma surgical devices that can be used. This is just a small portion of the different devices. I do want to talk a little bit about the evolution of how we're looking at MIGS from a training standpoint. This is very similar to the definition that I posed earlier in the talk. This is a definition by Ike Ahmed. And essentially what MIGS is offering is a decrease in intraocular pressure with a follow-up that's very similar to cataract surgery alone. When combining with cataract surgery, I always consent the patients for plus or minus the glaucoma procedure. Sometimes you do the cataract surgery and you just can't complete the glaucoma part of the procedure. So it's always good to have that conversation with the patient beforehand. I discussed recovery, maybe a little bit different than cataract surgery, where you might have to use steroids a little bit longer. Dilation and preoperative drops are pretty much as usual for cataract surgery. And then I discussed positioning prior to going into the case. You have to rotate the head 45 degrees, rotate the microscope 45 degrees. And it's good to have the patient realize that before going in, because they will sense the commotion happening when the nurses are helping with the microscope or when you're repositioning the head. And having them prepared for that, I think, goes a long way. For standalone, antibiotic plus pilocarpine is really the only difference. So instead of dilating, we add pilocarpine to constrict the pupil, otherwise as above. Intraoperatively, for your first few cases, use miotics so you can get a better view of the trabecular meshwork. It's not necessary, but I find it to be helpful. Find routine cases with cooperative patients. Consider peribulbar anesthetic. We can typically do all MIGS procedures with topical anesthesia. But for your first few cases, you might consider a peribulbar anesthetic because it might take you a little bit longer to complete. Hydrate the wounds very well and leave the pressure at 25 millimeters of mercury with a BSS fill and hydration of the wounds to make sure that there's no hypotony postoperatively that would cause blood to reflux back into the eye. A little bit different than cataract surgery alone as far as positioning your elbows instead of just being at the sides as you typically do with cataract surgery. In this case, you have one hand that's extended, one arm that's extended because of the gonial lens. In the case of cornea, the incisions are typically what you operate in. With cataract surgery, you're going through both incisions, as opposed to when you're combining with MIGS, you have one hand on top and one hand inside of the eye because you're holding the gonial lens. In the case of what your hands are actually doing, bimanual for cataract surgery, but the intra and extraocular movements that happen with a MIGS procedure should be practiced beforehand because it does feel a little bit different. And then again, the operative space, you're working within 1 millimeter in the angle and you have several millimeters when you're doing cataract surgery alone. So this is all, it might seem like minor differences, but it's certainly something that should be practiced before you do your first MIGS procedures. And this is what it looks like. On the left-hand side, cataract surgery alone. Right-hand side, you're doing a combined procedure holding a gonial lens. So the ergonomics are certainly different, and it's something you want to be comfortable with before your first procedures. Gonioscopy plays viscoelastic on the lens rather than on the eye. I find that putting a little bit on the backside of the lens prior to putting it on the cornea is a little bit better. You use less viscoelastic in that case. Rest the hand on the forehead or the zygoma, depending on which eye you're operating on. Don't use the lens to direct the eye. There's a tendency for the surgeon to want to direct the eye while holding the gonial lens, and that just causes stria on the cornea. So just have the patient position correctly and ask them to look the right way. And then zoom in, and that's the picture on the upper right-hand side. You basically want to see either side of the gonial lens during the procedure, and that gives you the proper magnification of the trabecular meshwork. This is one of my colleagues here in the US, John Berdal, showing a practice session before doing your first MIGS procedures. So what he's doing here is he's going in with his chopper and he's positioned the patient after standard cataract surgery. He's just practicing the motion, the right to left-hand side sweep that you do with many of these procedures. And that gives you an idea of what you might expect when you're first doing your first procedures. Wound construction is really important. You want to make sure that you're not touching any of the perilimbal vessels. If you have any oozing during the procedure, when you're doing a MIGS procedure, you might get some of the blood into the viscoelastic, which can obscure your view. So stay away from the perilimbal vessels and give yourself some room. I typically say 2.4 millimeter incision is good for your first few cases to make sure that you're not getting that oar locking in the wound, that you have enough space to move from right to left. And this is putting it all together. And what you're going to see here is a goniotomy procedure. This is a device that I had a hand in developing with New World Medical. It's basically a device that goes in and strips the trabecular meshwork. You see here a movement from left to right, followed by repositioning to the right-hand side and moving right to left. And you can see stable eye, stable movement, good view. And what you're getting here is a decrease in intraocular pressure by removing the trabecular meshwork entirely. And then you just go in with your duet forceps or any type of capsular access forceps and remove that strip of trabecular meshwork. At the conclusion of the case, we like to do this fluid wave. You can see in the upper left-hand corner the blanching of the vessels when you inject BSS into the eye. And that just indicates that you were successfully able to bypass the trabecular meshwork. And this is the strip of trabecular meshwork that you get at the end, which we've been having a lot of fun analyzing the different specimens, looking at what the process of glaucoma looks like and what trabecular meshwork can do in these cases. As far as looking at the effect of medication, the effect of different surgical procedures, we're starting to publish a lot on this tissue bank that we've developed. Post-operatively, very similar to cataract surgery alone. The drops are pretty standard with antibiotics, steroids, NSAIDs in some cases. And some surgeons choose to use pilocarpine to keep the angle open longer, but you don't necessarily have to do that. One thing that is important, though, is to watch out for steroid response glaucoma. Even if you remove the trabecular meshwork, these patients can still get an increase in IOP with steroids. And so what I like to do in this case is to keep the patients on at least one glaucoma medication while they're on their steroid therapy to avoid some of those spikes that we can see. So last question here, which statement is true? Glaucomatous eyes can still experience steroid response IOP elevation. MIGS approaches lead to more rigorous postoperative follow-up compared to CE alone. MIGS approaches rarely lead to decrease in IOP lowering medications, or all of the above. All right, all of the above was the answer that we have. So I'm going to move on to the answer slide and show you that. The answer here is glaucomatous eyes can still experience steroid response IOP elevation. MIGS approaches lead to more rigorous postoperative follow-up compared to CE alone. That's often not the case. It's typically similar to cataract surgery alone. MIGS approaches rarely lead to a decrease in IOP lowering in medications. Of course, that's why we're doing it, because it does decrease IOP and medication use. And so the proper answer here is A. So summary, standalone cataract surgery is an excellent IOP lowering procedure. Narrow angles in some but not all circumstances benefit from early cataract surgery. GSL is an important skill to master when caring for glaucoma patients in the operating room. MIGS procedures require diligent practice. We have to go in and do the practice before doing our first procedure so we get comfortable with the positioning. And learning specific angle-based surgery pearls can enhance patient satisfaction. Talk to your colleagues who are doing the procedure. Email experts that are out there that have been doing this for years and learn how to do it before going into your first cases. And I always like to close with this statement: we continue to learn from each other, and this is really important. I've learned a lot from talking to surgeons all around the world and visiting operating rooms all around the world. We each have our pearls and nuances, and so I'm happy to share with you some of my thoughts on this, and hopefully can learn from some of you during the question and answer session. Thank you very much. Lawrence, I'll throw it back to you for the question and answer. Can cataract surgery alone reduce the intraocular pressure? We definitely went through that in the first few slides, that you can see a robust pressure lowering in patients, especially those who start off with a very high intraocular pressure. So above that 22 millimeters of mercury, typically above 25 millimeters of mercury, those patients can see a robust IOP lowering. Now keep in mind, some of these patients might have an elevation in pressure, and so follow-up is really important. Can mitomycin C be used in combined surgery? Absolutely. So we use mitomycin C when combined with some of the MIGS plus procedures like the Zen implant, which is an ab interno implantation of a stent that drains fluid from the inside of the eye to the outside of the eye. In this case, what we do is we inject the mitomycin into the tenon's capsule. So rather than open up the conj and put the mitomycin on the sclera as we usually do with pledgets, more and more what we're doing for both of our trabs as well as the ab interno procedures like Zen is we're injecting the mitomycin in very small doses. We're injecting it posteriorly so that we can get flow posteriorly away from the limbus. And we're finding that to be quite successful. It also streamlines things in the operating room where we're able to not take as much time for the mitomycin to apply it and then wash it away. Decision-making between Phaco trab versus Phaco. Now, I have a huge bias here that I'll admit to. I don't like combining Phaco with glaucoma surgery. I know there are a lot of surgeons out there that prefer doing it that way. I found over the last 13, 14 years of practice that doing standalone Phaco or trab ends up a much better result for the patient. And typically what I'll do is I'll do the Phaco first, see what kind of IOP lowering I get, which can sometimes be surprising and quite robust. And that can influence what type of glaucoma procedure I do, whether it's a trab or I might do endocyclophotocoagulation. I might do a MIGS procedure in the angle with trabecular meshwork or suprachoroidal space. Doing that Phaco and seeing what kind of IOP lowering you get could actually help the patient get a less invasive glaucoma procedure down the line. And as you saw from one of my slides, I typically combine the Phaco with a minimally invasive procedure just to see what I can get. A lot of chronic glaucoma, high pressure glaucoma, they do surprisingly well with Phaco plus a minimally invasive option. Next question is, for what period pre and post-operatively would you recommend suspension of prostaglandin inhibitors in a patient with glaucoma? Another great question here. I don't stop my prostaglandin drugs, so Xalatan, Travatan, Lumigan, the trade names that we use in the U.S. There was a lot of thought in the past that these might increase the rate of cystoid macular edema post-cataract surgery. I only stop those for a few weeks, 4 to 6 weeks afterwards, in patients who might have a history of inflammatory diseases, in which case, to be honest, I typically don't have them on those drops to begin with. But I don't change my routine for prostaglandin analogs at the time of cataract surgery. And I think there's plenty of information to corroborate the fact that you don't need to do that, including the history of thousands of patients here at the University of Colorado, where we didn't find a link between the use of prostaglandins and the rate of CME after standard cataract surgery. How do you approach the surgery? Do you do them separately? I think I already answered that with number 4. How to do combined surgery, Phaco and Trab surgery. So again, a little bit of a bias here on my part that I don't combine the two. Now, certainly you can do same incision for cataract surgery where you lift up a flap and you do the cataract surgery through that flap and follow up with the Trab out of the same wound. More typically, surgeons who are combining the two have separate incisions where they do clear cornea for the Phaco, followed by a standard trabeculectomy, and I think you can use whatever you're most comfortable with. Is it possible to perform trabeculectomy after routine 12 o'clock, 6? Absolutely, you can still do that. You might run into, if you're doing a post-operative follow-up in a patient who had 6 surgery and then you ended up doing a trabeculectomy or needing to do a trabeculectomy, you might run into more scarring in this case and require a little bit more diligence as far as wound construction and closure of your conjunctiva. For combined surgery, of course, just refer back to my last answer. There are different ways to do that depending on your preference. Precautions while operating on a post-transaction or with superior bleb. Precautions when operating. So in this case, I think if you have a superior bleb and you're thinking about doing cataract surgery, the most important things is really just avoid any sharp instrumentation, particularly the Thornton ring, which a lot of us use to stabilize the eye during cataract surgery. That has significantly sharpened teeth on the bottom that can penetrate a superior bleb. So we tend to go a little bit more temporally in these cases to stay away from the superior bleb. One thing I will add here is if you're going in and doing cataract surgery on a patient who does have a bleb, at the end of the cataract surgery, it might help to needle or to tease away some of the scar tissue in that bleb at the end of the case. One way to do that, a very elegant way to do that, is to get a cyclodialysis spatula, fit it in through the clear corneal incision that you use for the cataract surgery, and then bring the distal end of that cyclodialysis spatula through the sclerotomy, work your way into the bleb, and you can actually lift up the scar tissue from an ab interno approach using that cyclodialysis spatula to lift up on the Tenon's capsule that might be scarred down. That's one thing that you can do to decrease the chances of that superior bleb scarring at the end of cataract surgery, which unfortunately can happen at times when you raise some of the inflammation that can happen after cataract surgery. It could influence your bleb. So doing that procedure with the cyclodialysis spatula will increase flow and potentially allow that bleb to survive much longer. What could be the approach in a patient who has a wide excavation of the optic disc and obviously with glaucoma? What could be the approach in a patient? So basically, the way that I understand this question is, what do you do for patients with advanced glaucoma when it comes to combining with cataract surgery? This is not a straightforward question. Now, it depends on your comfort level with the amount of MIGS procedures that you've done. It is rare for me not to consider doing glaucoma surgery combined with 1 or 2 minimally invasive procedures before I go to a trab and a tube, no matter what their disease status is. Now, if a patient has split fixation, I'm worried about them worsening because they have a 0.99 cup and their target pressure is 12 and they're starting out with a pressure of 25. In those patients, I certainly go to a trab or a tube standalone. But in patients who have elevated intraocular pressure, they're going through cataract surgery, typically I'll do a MIGS procedure, sometimes combined with endocyclophytocoagulation. So ECP, endolaser with a diode laser. at the same time doing an outflow procedure like an eye stent, Hydrus, a CyPass, or goniotomy with KDB. In these cases, if you combine inflow and outflow, ECP plus an angle procedure, you can get very robust IOP lowering with a cataract surgery, even in patients with an optic disc that is advanced as far as glaucomatous optic neuropathy. So it really is the art of medicine here. What are you comfortable with? What do you see in your own hands? And how much do you want to stay away from a bleb when it comes to a trab or a tube, which in my case is I want to do everything possible to avoid a bleb if at all possible. What is your experience on IOP reduction after cataract surgery and pseudoexfoliation glaucoma? These patients tend to do very well early on in the process because you've washed away much of what's plugging the trabecular meshwork. Now, unfortunately, these patients tend to have a rise because the pseudoexfoliation process does not stop after cataract extraction, and you can still see a rise in intraocular pressure that happens with time, and you have to go back in and do something more definitive in many of these patients. We certainly do start out with cataract surgery alone whenever possible and try and push away glaucoma surgery whenever possible. Incidentally, these patients also do very well with a goniotomy, just removing that trabecular meshwork in order to get as much flow as possible without plugging of the trabecular meshwork. When performing a phaco trab, is it best to use an AC maintainer or use Helon in the AC? Now, my experience, and I've done both of these with an AC maintainer or with a viscoelastic, any viscoelastic, not just necessarily Helon, I find that the chamber is much more stable with a viscoelastic in the eye rather than an AC maintainer. Now, there are cost issues, access to different viscoelastics, which I understand, and in that case, AC maintainers are adequate, but you tend to get more of a fluctuation in the anterior chamber, which can predispose you to bleeding or even suprachoroidal hemorrhages, and that's why I like viscoelastic in these cases. It just maintains the chamber better for me. When should we consider cataract surgery alone in patients with cataract and glaucoma? I think we've answered that extensively. There are many circumstances where cataract surgery combined with glaucoma surgery makes a lot of sense. But I think you've seen from some of the data that patients, even with high pressure, can do very well with cataract surgery alone. So a lot of this is what's the status of the optic nerve. If it's early disease, then cataract surgery alone and watching how the patient reacts is very appropriate. If the glaucoma is moderate to severe, then going in with cataract plus a glaucoma procedure, in many cases a MIGS procedure, combined with an inflow procedure like an endocycler photocoagulation would be the way to go. So a lot of this is nuanced, depends on the patient, what the disease status is, and how many medications they might be on. And this final question, what anesthesia type is best for eyes with glaucoma? I think that the best anesthesia is the anesthesia that I would want, which is topical therapy for almost all procedures except for tube implantation. I found that patients with trabs or any of the MIGS procedures do very well with topical therapy. Of course, in the case of trabs, we can augment with a subtenon's injection of lidocaine and bupivacaine. In cases of glaucoma drainage devices, peribulbar or retrobulbar anesthetic, in my experience, has been the most comfortable thing for patients, also giving them hours of relief post-operatively to make them comfortable. So in this case, I would say topical anesthesia is always my go-to, and rarely do I use a retrobulbar for any of the procedures other than a glaucoma drainage device, where I try and go for maximum anesthesia to give the patient comfort and to give me comfort during the procedure itself so that the eye isn't moving and I don't feel like any type of manipulation is causing discomfort for the patient. From anonymous attendee, how about in remote areas where there are no glaucoma specialists, do you advise general ophthalmologists to do this? So if the question, what the word this means, I think that any ophthalmologist who is getting training and practicing in MIGS procedures or angle procedures can do any of the procedures that I just talked about. Cataract surgery itself, if the general ophthalmologist is performing that, which I assume they would be in this case, then they can do eye stent, they can do goniotomy, they can do any type of laser procedure if they have access to it. In cases of remote surgery, a lot of times expense is an issue, of course, and that's the case certainly in many places around the US and around the world. I try to go to less of the implant procedures because they're in many circumstances cost prohibitive. So a goniotomy procedure I think is very much achievable for the general ophthalmologist. If you can do a capsulorhexis, you can certainly do a goniotomy. So I would look and I would tailor the therapies to the certain specific environment that I'm in. From a post-operative standpoint, you're not really adding a lot of post-operative rigor. So if you're in a remote area where people are traveling in for the surgery and they have to travel back where the care might be less skilled, I think doing these procedures is actually the way to go compared to a trab or a tube, because you can essentially do what you're doing for cataract surgery alone, and the patient tends to do very well. So that's how I would answer it. I think the MIGS procedures and the ab internet procedures lend themselves very well to general ophthalmologists in very remote areas, especially in circumstances where you're not tagged to any type of energy, electricity, any type of implants that might be cost prohibitive. There are many, many options that you can use in specific geographic areas.
All right, so it looks like that's all the questions. So thank you, Dr. Kahook, for your time.
Yep, thanks everybody for listening. And,
have a great day.
Yep, thank you, Lawrence.